So we'll do the review tonight. I do a PowerPoint with you guys, like my class knows. I don't feel great. I have a regularly bad cough. So I'm going to try to get through it as much as I can. If I have to call it early, I'll let you guys know. Let me also open up the PowerPoint that we're going to use tonight so that, let me see here. I'm going to use the PowerPoint. So everything, 50 questions, 75 minutes, 5 math. Make sure you guys know your math. Here is our PowerPoint exam review. I will start that with you guys. Let me see, where's my Zoom here? I will start that with you guys. We're going to share it. One of the other professors created this, so we're going to use hers because that way we're all saying the same stuff. You guys don't have to have your cameras on if you don't want to. Oh, what just happened? I'm going to stop sharing and share again. You don't have to if you don't want to, but of course, always be here. I'm here if you have any questions. So exam 2, we have chapter 18 through 21, 11, and 12, and 17. A lot of content here. So let's go over some of the content and see what we got. We're going to start off with our ethnocentrism, cultural competency, and cultural relativism. 3 different things we need to know about a belief in the rightness of one's culture, asking how to accommodate, and when something is relevant to what is going on. We talked about diabetes. There's pre-gestational and gestational. So pre-gestational, you have it before you're pregnant. Remember the metabolic changes that go on with diabetes. You're going to have a change in insulin needs. It's going to peak and go up higher. We need to make sure during first trimester it's very well controlled for cardiac. Know about our insulin resistance. Sometimes we have that. Decreases quickly after delivery. And then when breastfeeding is almost like running a marathon. So you're going to be using a lot of insulin. Okay. Care management, we're going to do our levels daily. Glucose monitoring is better than A1C because remember A1Cs are an average. So just remember that. We're going to make sure we're watching for fetal heart, for watching NST. So we're going to have that fetal heart rate checks frequently, kick counts, and ultrasounds. Risks with diabetes, you're going to have those big babies. You may have neonatal low blood sugar. You might have macrosomia, birth defects and cognitive abnormalities if you have poor glucose control. So very important for your diabetics to have good control before they're pregnant. Preeclampsia infection, ketoacidosis we see can occur. Our cardiovascular disorders, we talked about using the heart. The heart is really a big organ. We need to use it. And so we want to minimize the stress. So if you have a compromised heart to begin with, during pregnancy, it's going to be worse. So we're going to, avoid straining. We're going to manage discomfort, things like that. Preeclampsia or high blood pressure during pregnancy. Remember, we got our protein in our urine. We have a rising blood pressure, and then we're going to have edema. So we're going to have that swelling in the face and hands particularly. We know that our circulation is going to be a little not as great. Oops. Preeclampsia diagnosis. We look for platelets that are lower than 100,000, impaired liver function, edema, any visual symptoms. And our risk factors are going to be our obesity and gestational diabetes, chronic hypertension. HELLP syndrome can occur after high blood pressure. That's our hemolysis, elevated liver enzymes, low platelets, HELLP. So we're going to watch our labs, our liver enzymes, our platelets, our fibrinogen, and our H&H to see what our labs are doing. Okay. Mag sulfate, something we do give for preeclampsia. Got to be really careful with it. It is used to prevent seizure activity. Also, we know it stops contractions. We talked about that this week. 4 to 6 grams is our loading dose, and then we do 2 to 3 hours, 2 to 3 grams per hour after delivery for 24 hours. We know that we are excreting it in the urine. We want to watch our INOs. We're going to look for fetal sedation because that does happen. Monitor our reflexes, our lungs, any body changes. Okay. Calcium gluconate IV is given antidotally if needed. Eclampsia is going to be those seizures that come if they're preeclamptic, and so we know we need to keep our airways and safety with our ABCs. We have some hemorrhagic disorders, so that's going to be like our bleeding. We have ectopic pregnancy, which can be tubal, abdominal, ovarian. You're going to have abdominal pain, spotting, things like that. That's not a baby that's viable. Okay. We have spontaneous abortions before age of viability. So what that means is that they lose the baby before they're able to survive. Can be because of a cervical insufficiency or cervical weakness. And always, you have a history of 3 or more preterm babies, you know, are going to be a thing. Cerclage is when you tie a stitch so that your cervix doesn't open. We have placenta previa, which is going to be when the placenta is on the lower part of the cervical os or close to it. Painless bright red bleeding, so we're going to deliver quickly by C-section. Spontaneous separation of the placenta is an emergency, really. You're going to have sharp abdominal pain, dark red vaginal bleeding, baby's not getting the oxygenation that it needs. So both of them will present with bleeding. Previa will be silent, and abruption is pretty quick onset and severe pain. Know the difference between those two. DIC is what happens after this, where you have this uncontrolled bleeding that happens. You're gonna watch for that and be very careful with DIC. Those are going to be some of your labs you're going to look at. Are your clotting factors working? Things like that. Trauma during pregnancy, we know, is very frequent. If there is trauma, we want to do our RH factor, make sure there's no blood to blood with mom blood and baby blood mixing together. You have your hyperemesis, where you're vomiting all the time and you get dehydrated, weight loss, deficiencies. Small frequent meals, dry, bland, high protein diets. It's going to help with that. Preterm labor, we talked about that, less than 37 weeks. Progesterone is a good one for history of preterm labor. We have our It's Not My Time, our tocolytics, indomycin, magsulfate, and terbutaline to stop the preterm labor. Antibiotics we talked about tonight is a good thing to give. It can sometimes slow down that preterm labor. Meconium stained fluid, when we have a baby who's post-term, oftentimes they will have their first bowel movement in utero. It puts them at risk for aspirating that, okay? And so we'll have respiratory distress. Sometimes we have really quick labor. What can happen is the uterus can rupture because everything goes so quick. You can hemorrhage, have a hematoma. Oftentimes we're going to see this quick labor with our drug users, so recent drug use is a definite precursor for that. When we're going to do when we're going to do an induction of labor, it means we're going to bring labor on for some reason. Elective, without medical indication, mom wants it, you're going to be at 39 weeks. And we'll look at a Bishop score and see how close they are. Cervical ripening things we use, Cytotec, Cervidil, prostaglandin. Make sure we have that. Our choreo, remember, is when you have that infection intrauterine. And so you'll have a fever, you have quick heart rate, and sometimes foul smelling fluid. We look at a C-sectional birth. Usually they will cut down horizontally through the first crease. But if they have to do a vertical for a stat section, they will do that. And that just gets the opening wider, quicker. Some emergencies we talked about this week: shoulder dystocia. So sorry. Where the head's out, the shoulder gets stuck. What do? You try to reposition the mom and try to get that shoulder out. Sometimes it will break. And that's one of our Mech-Roberts maneuvers, which you see right here. You have them push your legs out and pull them right back in, and that'll help with bending of the bone there. All right, this is an obstetric emergency. When you have a cord prolapse, that means the cord comes out before the baby. The problem with that is that the baby's not getting its oxygenation. So you have to stay with the patient. You glove up and you put pressure on the presenting part. So you lift up the baby and keep your fingers, the cord in between your fingers, as to keep that cord getting the blood flow through it. Okay, so we take a look at that, and here's some pictures, pretty things. All right, postpartum assessment, we're going to do bubble. So it's going to be breast, uterus, bladder, bowel, lochia, and your episiotomies you're going to look like. Homan sign, you're looking for DVTs, and emotional, of course, your postpartum depression screenings. With our uterus at postpartum, we should start to see it to go down, 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 down. Now remember, it takes 9 months to get really big and full, and then we expect by day 9 for it to be down, okay? If it's not going down, then something is not right. Sometimes we have to massage it to have the whatever blood is stuck in there to get out, okay? So it should always be firm, never boggy. Bowel and bladder, sometimes the bowel takes a while because you've had a laceration or a cut down there and people are afraid to use the bathroom. Bladder, another one, they're afraid to go to the bathroom. They're afraid to anything come out of there after the baby has. Lochia, we're going to look at, oops, how much bleeding is coming out. Uh-oh. Sorry about that. Let's stop sharing for a minute. So our lochia, we're going to look at the amount, the quantity. What happened to my little thing here? All right, here it is again. I don't know what happened there. Sorry. Okay, so we're looking at our lochia. How much do we have? We have our rubra, first few days, serosa, and then alba. Okay, alba can go for 4 to 8 weeks postpartum. So we're going to look at color, size of clots, odor, how much is too much. Okay. Bleeding management, we're going to massage that fundus, make sure that it gets firm, IV fluids, make sure our vital signs are stable, make sure we've done all our postpartum Pitocin to get that uterus. If the uterus is at knee, then you need to do something to get it to firm up. So there's some other things you can do here. Contraindications for Methogen is our hypertensive patients, and Hemabate is our asthmatics. All right, cesarean lacerations and episiotomies, they're cuts. So you're going to do what you would do with any laceration, assess for redness, edema, ecchymosis, discharge, and approximation, okay? We're going to make sure we're cleaning it, keeping it clean with soap and water. Cesarean, same thing on your incision. Attachment and bonding, we make sure that we see eye contact, touching, holding, talking, participating in care. We want to do skin to skin right after birth. That means baby skin to mom skin or baby skin to dad's skin. We're going to keep an eye out as a nurse for those kind of attachments. We have different emotional statuses that we looked at, and that's in one of your crosswords. We have our baby blues, which is like peaks around day 5 and kind of goes away by day 10. We have postpartum depression, which is going to be much more intense. It's going to last more than 2 weeks. They're going to have some detachment. We have our postpartum psychosis, which goes even further. Our treatment, we're going to look for those symptoms, teach sleeping when the baby sleeps, get outside, get some fresh air, all our antidepressant treatments, okay? Medications, I want you to know, oxytocin we use for labor induction and postpartum, mag sulfate to prevent seizures, calcium gluconate is what we use to stop our mag sulfate if they are too dosed, if it's too high. Terbutaline, okay, can cause some tachycardia. Remember TNT. We have betamethasone, which we give for fetal lung maturement. And a lot of times you'll see that with a diabetic, but with the diabetic, it's a steroid. So remember, diabetics, it will cause an increase in their blood sugars. Some more hydralazine, labetalol, insulin, methotrexate. We're going to have methadone, which is something that a lot of the women will go on while they're, if they're addicted to opioids. We have prostaglandin. And then there's some case studies that are on this PowerPoint that we're not going to go through. But I want you to think about all the things that we've covered. For your meds, you're going to have 5 problems on your test. So look at this PowerPoint that is in your exam ready. Okay, let's do a quick question. Ultrasound is performed on a client at term gestation who's experienced moderate vaginal bleeding. The results indicate abruption, placental abruption. On the basis of these findings, what are we going to prepare for? The placenta has abrupted. What are we going to do? 1, 2, 3, or 4?
1. Oh, you want
Anybody else?
Yeah.
Answer is 1. Why? It's an emergency. We got to get the baby out. The placenta has abrupted. So make sure that that is done. All right, teaching a person with diabetes about nutrition and insulin during pregnancy. We know that dietary and insulin needs, if the second half of pregnancy requires more insulin or less insulin.
1.
More.
Good. Increased insulin. Excellent. It goes up and then it goes down. So we have high demand for glucose there. IV mag sulfate, what are we going to make sure we check for? What's our highest priority?
Four.
Anybody worried about 2? We should be thinking about 2. You know why we should think about 4? We always have 4 on hand just in case of the mag. But that number 2 is checking for your deep tendon reflexes, remember? So always important to assess those. All right, blood pressure during the past 3 weeks has been averaging 130/90. Swelling and mild protein in your urine. Which statement should alert the nurse that something's getting worse?
1.
Okay, 1, because 2, 3, and 4, she's getting better. Right? She's going to have heartburn. They're going to have heartburn. That's not necessarily. Epigastric pain can sometimes be a concern, but it's always going to be 1. Let's see this one. All right, gestational age of premature rupture of membranes. Gestational age of the fetus is 37 weeks. What should the prescription question? What is wrong here? What should we not be doing?
3.
Why?
Well, first we're going to be introducing infection and bacteria.
Good. You're going to monitor that fetal heart rate. You're going to monitor maternal signs for choreo, for that infection. You're going to do antibiotics. So you don't want to be doing a vaginal exam unless you need to, because you're going to be introducing bacteria to something that should not be. All right, uterus is soft and boggy. What should we do?
2.
You're always going to massage the fundus. That's always the answer if they're boggy. Okay. All right, fever and fetal tachycardia are symptoms of what? On a pre-ruptured ruptured membranes.
1.
Choreo, yeah, infection. All right, mag sulfate for neuroprotection, okay? So we're gonna do neuroprotection to try to help the baby, okay? So, or depends really on a preterm, if we're helping for the baby. All right, let's see. What are we gonna assess for? I don't care why the patient's getting mag.
2 and
2,
5.
3, 4. 2, 3, 4.
Yeah, 2, 3, 4, and why 2, 3, and 4? Because our signs of mag toxicity are going to be respiratory depression, altered level of consciousness, lethargy, and absence of deep tendon reflexes. All of those need to be checked constantly, okay? Usually protocol is every 4 hours if they're on mag. We didn't talk much about that, so I'm going to skip that. All right, why would we discontinue oxytocin?
4.
4.
Yeah, late decelerations we know are bad. What else might be bad?
3.
Yeah, you don't want that uterus going crazy because it can pop. So 3 and 4 are going to be our answers, right? RH positive. All right, during a 38-week prenatal visit, the nurse assesses the fetal heart rate to be 180 beats per minute. What does she think might cause tachycardia? 38
One.
weeks.
Infection.
Yeah, infection is usually going to cause elevated heart rate on the baby. So make sure if you see something like that, you do worry about that, okay? And a topic we talked a little bit about. Okay, any questions at all? No? All right, if anybody needs or would like private tutoring, I'm available. Please be in contact with me. Thank you for joining our exam review and cooperating with my sore throat and all that good stuff. And best of luck to everybody next week on the test.
Thank you.
You're welcome.
Hope
Good
you
night.
feel better.
Thank you.